Welcome back to the Deep Dive. Today, we're shifting gears a little. We're stepping away from the bedside, walking out of the patient's room, and leaving the hospital entirely.
We're zooming way, way out.
Exactly. We're putting on our detective hats. If you're a nursing student, you're probably spending, 90% of your time zoomed in?
Oh, absolutely. You're looking at microscopes, you're memorizing cellular mechanisms, checking every single drug interaction.
But today, we are looking at the big picture. We're talking about the health of entire populations.
And that's a massive shift in perspective. Usually in nursing school, the whole spotlight is on the patient in the bed right in front of you. It's nursing of the one.
Right.
Today, we are looking at the community outside that hospital window. We are diving into three massive interconnected topics: epidemiology, communicable disease, and environmental health.
And I know what some of you might be thinking, oh great, statistics, graphs, dry definitions.
The fun stuff.
But trust me, the sources we've been looking at today, they paint a picture that is anything but dry. We're talking about, life and death detective work.
We really are. We're talking about how you stop a disease before it even walks through your clinic door.
And that's the key. This isn't just about memorizing definitions to pass the NCLEX.
Though, to be clear, the concepts we're discussing are absolutely critical for
Oh, for sure. But it's about transforming how you see your role. We want to take these textbook definitions of epidemiology and turn them into, practical tools for your nursing toolkit.
Because the truth is, you can't fully heal a patient if you don't understand the world they're going back to. It's just that simple.
So our mission today is pretty straightforward. We're going to trace the line from the ancient history of disease tracking all the way to modern crises, like the opioid epidemic and COVID-19.
We'll dig into the math of outbreaks.
And then we're going to give you a literal mnemonic you can use to assess a patient's home environment for hidden killers.
It's a journey from the very theoretical to the intensely practical. And it all starts with a word that sounds a lot more intimidating than it actually is: epidemiology.
Let's unpack that word. It feels so academic, but the etymology, the origin of the word, it actually tells the whole story, doesn't it?
It really does. It's actually quite poetic when you break down the Greek roots. It comes from epi, meaning upon, demos, meaning people, and lalology, which is this study of...
So quite literally, it's the study of what is upon the people.
Exactly. What is upon the people.
That feels heavy. It feels almost biblical.
It is heavy. And historically, we thought of what is upon us as just bugs, infectious diseases, plagues.
Right.
But modern epidemiology is much, much broader. The textbook definition is the study of the distribution and determinants of health-related states.
Which is a very fancy way of saying it includes everything.
Pretty much, right. It includes chronic diseases, accidents, violence, mental health, environmental exposures. It's the science of understanding why some people get sick and others don't.
Okay, so let's distinguish it from clinical medicine. If a patient comes into the ER with a broken leg, the doctor or the bedside nurse, they fix the leg. That's clinical care. The epidemiologist asks, why are so many people breaking their legs on this specific street corner?
Precisely. And the public health nurse is the one who goes to that street corner, realizes there's a massive pothole or a patch of black ice, and gets it fixed.
The clinician treats the trauma. The epidemiologist treats the pattern.
I love that distinction. Treating the pattern.
So let's go back, way, way back.
Yeah.
Because we are not the first ones to notice these patterns. Who started this whole disease detective business?
Well, if we want to go to the very beginning, we have to tip our hat to Hippocrates. We're talking 460 BC.
Wow.
Before him, if you got sick, the assumption was often supernatural. You angered a god, you broke a taboo, maybe you were cursed. Hippocrates was the first to say, wait a minute, maybe it's not the gods.
Maybe it's something
Maybe it's the air, maybe it's the water, maybe it's where we live.
So he was the first to look for environmental causes.
Right. He wrote this famous text called On Airs, Waters, and Places. And in it, he distinguished between things we can't control, like the weather or the seasons, and things we might be able to, like our water sources or housing. It was really the birth of rational observation in health.
But he didn't have the tools to prove it, right? the data tools.
No, he didn't. The real father of epidemiology, the man who turned this into a data-driven science, is John Snow.
And just to clarify for all the pop culture fans listening, we are not talking about the guy from Game of Thrones.
No, definitely not. We're talking about a physician in London in the mid-1800s, and this is a story every single nursing student needs to know because it just perfectly illustrates the power of observation and critical thinking.
Okay, set the scene for us. It's London, 1854, the Soho district.
It's basically a nightmare of sanitation. It's crowded, it's dirty, there's no modern sewage system, and there is a terrifying outbreak of cholera. Now, you have to understand the mindset of the time. The prevailing scientific theory was miasma.
Miasma, that's the bad air theory, right? The smell.
Yes. They thought disease was caused by foul smells, arising from rotting organic matter or the soil. And to be fair, London probably smelled terrible back then.
I can only imagine.
So when people got sick, experts said, it's the smell, it's the miasma.
But Jon Snow was a skeptic. He didn't buy it.
He didn't. He suspected it was something people were ingesting. He thought it was in the gut, not the lungs. So when this outbreak hit Soho, he did something revolutionary. He didn't just treat patients, he grabbed a map of the district.
This is the famous spot map.
Exactly. He walked the neighborhood, literally doing foot patrols. And for every death from cholera, he placed a black dot on the map at that person's address.
He was doing manual data entry.
Totally. And as he placed these dots, a chilling pattern started to emerge. The deaths weren't random. They weren't spread out by air currents or something. They were clustered tightly around a specific public water pump on Broad Street.
It's so fascinating because he looked at the context of the deaths. He was doing what we now call surveillance. But he went even further. He looked for the outliers, right? The exceptions.
He did. And this is the mark of a great detective.
Wow.
There was a brewery right next to the pump where almost no one died.
And why was that?
Because the workers drank beer, not water.
Of course.
And then there was this one woman who lived miles away in a perfectly healthy area who died. And they figured out why. She just liked the taste of the Broad Street water and had her son bottle it up and bring it to her every day.
That was the smoking gun.
It was. The data was so compelling that he convinced the local council to do something pretty drastic. They removed the handle from the Broad Street pump.
They physically disabled it. So people just couldn't drink the water anymore.
And the epidemic subsided. It was one of the first major public health interventions based purely on data analysis. He didn't have antibiotics. He didn't even know what bacteria were yet. Germ theory hadn't really taken hold.
Right.
But he stopped the disease just by changing the environment.
That is the essence of public health nursing right there. You don't always need a prescription pad. Sometimes you just need to remove the handle.
Exactly.
But speaking of data and nursing, we have to talk about the mother of this field. Most people know Florence Nightingale as the lady with the lamp, comforting soldiers. But our sources paint a very different and much nerdier picture.
Oh, Florence was a powerhouse statistician. She was arguably the first nurse epidemiologist. When she arrived at the Crimean War, the mortality rate for soldiers was just horrific. But she didn't just provide bedside care, she started counting. She was obsessed with data collection.
She realized that the enemy wasn't just the opposing army.
Correct. She realized that more soldiers were dying from typhus, cholera, and dysentery, all diseases of poor sanitation, than from actual battle wounds. The hospital itself was killing them.
And she needed a way to explain this to the stubborn politicians and the military brass back in England who didn't want to spend money on hygiene.
So she invented what she called wedge-shaped graphs. They're precursors to the pie charts or rose diagrams we use today. And she used this data visualization to prove that sanitary reforms, like cleaning up the water, improving ventilation, better food, drastically reduced the death rate.
She didn't just say, it's dirty here. She showed them the math.
She basically used data to shame the government into action.
Wow.
And she won. She proved that nursing is as much about the environment and rigorous data analysis as it is about empathy. For the students listening, this is your heritage. You're part of a lineage of data detectives.
So we have the history. We know where we came from. Let's get into the toolkit. If I'm a nurse looking at a population today, what are the mental models I need to have in my head? The sources mentioned the epidemiologic triangle.
This is the absolute classic model. If you are taking an exam, you need to visualize this. Imagine a triangle. At the three corners, you have the host, the agent, and the environment.
Okay.
Disease happens when these three interact.
Let's break those down because they seem simple, but the definitions are pretty specific.
They are. The agent is the what. It's the cause. In infectious disease, it could be a virus, a bacteria, a parasite.
Got it.
But it can also be a chemical, like a poison, or a physical force, like a bullet or a car crash, or even a nutritive factor, like a lack of vitamin C causing scurvy.
Okay, so the agent is the bullet or the bug. What about the host?
The host is the WHO. It's the living being that gets sick. But in epidemiology, we look at the intrinsic factors of the host,
Really?
meaning things like genetics, age, immune status, lifestyle choices. Not all hosts are the same. Some are just more susceptible than others.
And the third corner, the environment.
The environment is the where. It's all the external factors that allow the agent and host to meet. So climate, housing conditions, sanitation, crowding, access to healthcare,
Yeah.
all of that.
Okay, let's apply this. A concrete example from the text. West Nile virus.
Perfect example. So the agent is the West Nile virus itself.
Okay. Yeah.
The host is the human, though, again, susceptibility varies. Older adults often get sicker. But the environment is the crucial piece here. It's standing water, it's mosquito season, it's warm temperatures.
And the nurse's job is to look at that triangle and figure out which side you can break.
Exactly. We can't easily change the host's genetics. We can't always kill every agent. But we can change the environment. If you get rid of the standing water, you break the connection. You stop the disease.
That makes a ton of sense for infectious stuff. But the text mentions that this triangle gets a little wobbly when we talk about chronic diseases like heart disease or diabetes.
That's a great point. You can't pinpoint a single agent for heart disease. It's not like a bacteria you can just catch.
Yeah.
And that's where we move to a more complex model. The web of causation.
The spider web.
Yeah, the spider web. Imagine a spider web. In the center is the health outcome, say infant mortality or cardiovascular disease. And radiating out from it are dozens of interconnected threads.
Okay.
Genetics, diet, stress, pollution, poverty, access to care, education level, they all pull on each other.
So if you just pull one thread like giving a patient blood pressure medication, you might not actually fix the problem if all the other threads are still tight.
Exactly right. It shows us that chronic diseases are multifactorial. A nurse looking at this web realizes that just telling a patient to eat better might fail if that patient lives in a food desert, that's the environment thread, or works 3 jobs and has impossibly high stress, that's the lifestyle thread. You have to see the whole web to find the most effective places to intervene.
That is a crucial distinction. Now, before we move on, there are 2 terms that constantly trip students up on exams.
Yeah.
I know they do. Incidence and prevalence. We need a cheat sheet for this.
This is the classic stumbling block for sure. Let's use the bathtub analogy found in the sources. It's honestly the best way to visualize it.
Okay.
Imagine bathtub. The water flowing into the tub from the faucet represents incidence.
Incidence equals new water. The new cases.
Correct. Incidence is the number of new cases occurring over a specific period of time. It's a rate. It's like a video recording of the water flowing in. If there's a flu outbreak, the incidence is high. The faucet is on full blast.
So what's prevalence then?
Now look at the water that's already sitting in the tub. That is prevalence. It's the total number of existing cases at one specific point in time. It's more like a snapshot.
So let's play this out. If we have a disease that people live with for a long, long time, like HIV or diabetes,
Then the prevalence, the water level, gets higher and higher, even if the incidence, the faucet, slows down. The water stays in the tub because people aren't leaving the pool of sick people. They're surviving.
so paradoxically, a high prevalence can sometimes be a good sign.
Exactly. In the case of HIV, high prevalence means our drugs are working. People aren't dying. They are living with the condition.
Oh, okay.
Conversely, think about a disease like Ebola or untreated pancreatic cancer.
Very high mortality.
Right. The water drains out of the tub through death almost as fast as it comes in. So you might have a high incidence, lots of new cases, but a low prevalence because there are very few people alive with the disease at any one moment.
That is such a helpful way to picture it. Okay, one last pair of terms for the vocab quiz. Morbidity and mortality.
This one is simpler. Mortality is death. Morbidity is illness or sickness.
So you can have high morbidity but low mortality.
Exactly. Like with the common cold or chickenpox. Lots of people get sick, high morbidity, but very few people die low mortality.
Got it. Okay, let's fast forward to right now. Part 2 of our deep dive. We're looking at modern epidemics. The sources highlight 2 big ones that are really defining our generation, the opioid crisis and COVID-19. Let's start with opioids.
This is such a tragic example of how epidemiology tracks a crisis as it evolves in real time. The data shows this epidemic didn't just happen all at once. It hit the U.S. in 3 distinct waves.
It morphed. It changed its shape over time.
Right. So wave one started back in the 1990s. This was the rise of prescription opioids. We saw a massive increase in prescribing pills like OxyContin for pain, and overdose deaths followed right behind.
This was the era of pain as the fifth vital sign.
Exactly. And then came wave two around 2010. As prescriptions got harder to get because of tighter regulations, people who were already addicted, well, they shifted to the street market. So we saw a huge spike in heroin overdose deaths.
But wave three, which started around 2013, is maybe the deadliest of all.
Yes, this is the rise of synthetic opioids, specifically fentanyl.
The sources have a shocking stat here. Fentanyl is 50 to 100 times more potent than morphine.
That potency changes everything. It means a tiny amount, we're talking a few grains of salt, can be lethal. And for nurses, especially in the ER or for first responders, this is a workplace safety issue too. There's a real risk of accidental exposure.
But epidemiologically, looking at our triangle, the agent itself just became so much more lethal.
Correct. The agent evolved, and now we're seeing polydrug use fentanyl mixed with xylazine or cocaine. The web of causation is just getting messier and messier.
Let's move to COVID-19. This pandemic introduced the whole world to some very nerdy epidemiologic math. Suddenly, everyone on the news was talking about R0.
Yeah.
What does that actually mean?
R$, or the basic reproduction number, is essentially a measure of contagiousness. It asks a simple question. In a population where everyone is susceptible, if one person gets this disease, how many other people, on average, will they infect?
Okay, so if the dollars is 1,
then one person infects one person. That person infects one more. The disease stays steady. It's what we call endemic. It doesn't explode, but it doesn't go away.
And if dollars is less than 1?
The disease eventually dies out. The chain of transmission is broken. This is the goal of public health.
But if dollars is greater than 1?
That would have exponential growth. Early estimates for COVID-19 put the dollars somewhere between 1.5 and 4, and that's why it spreads so explosively. If it's 2, then 1 becomes 2, 2 become 4, 4 become 8. It just snowballs.
Wow.
Measles, by the way, has in dollars of about 12 to 18.
12 to 18. That explains why measles outbreaks move so incredibly fast. And this connects to herd immunity, right? Because the math of herd immunity is directly tied to that taller dollar number.
Precisely. Herd immunity is when enough people are immune, either through vaccination or prior infection, that the virus just can't find a new susceptible host. It hits a dead end. And the math is direct. If a virus is super contagious, meaning a high tolerance, you need a huge percentage of the population to be immune to stop it.
So for COVID, with another dollar of, say, $4, you need something like 75% immunity. But for measles, with dollars of 18, you need like 95%.
Exactly. It really puts the vaccination efforts into perspective. It's a numbers game. And speaking of numbers, the sources also talk about the case fatality rate for COVID and how it really highlighted these massive disparities. This is where we see the host factors really matter. The case fatality rate, the percentage of infected people who die, was drastically different by age. Early data showed it was about 1.4% for people under 60.
Okay.
But a staggering 13.4% for those over 80.
An epidemiologist looks at that and immediately says, we need to protect the nursing home.
Right. Data drives the strategy. We also utilize something called the SIR model.
SIR. Break that down for us.
It stands for susceptibles, infectives, and removed. It's a way of modeling how a population moves through an outbreak. So you start with everyone in the susceptible bucket. As they get sick, they move to the infective bucket. Then they either recover with immunity or they die. And either way, they move to the removed bucket. And the goal of a vaccine is to move people from susceptible directly to removed with immunity without them ever having to go through the infective or sick phase.
That's a great visualization. Skipping the middle step entirely. Okay, let's transition to part 3. Communicable disease control. We've identified the bugs. How do we fight them? The sources emphasize the 3 levels of prevention. And I know for a fact this is on every nursing exam ever written.
It absolutely is, and for good reason. It frames every single intervention a nurse does. You have primary, secondary, and tertiary prevention.
Let's walk through them. Primary prevention.
Think prevention with a capital P. This is stopping the disease before it ever happens. The goal is to keep the host healthy and keep the agent away.
Give us some examples.
Immunizations are the classic one. If I give you a measles vaccine, you never get measles, period.
Right.
Other examples are things like health education teaching kindergartners to wash their hands, or sanitation building clean water systems, or using condoms to prevent STIs. It's all about blocking the start.
Okay, so that's primary. What's secondary prevention?
Think screening. Secondary starts with S. Screening starts with S. The disease might be there already, but it's early. We want to catch it while it's asymptomatic or easily treatable.
So a TB skin test would be secondary.
Exactly. Or a mammogram.
Right.
Or colonoscopy. Or checking a child's lead levels. You aren't preventing the exposure that might have already happened, but
Yeah.
you're trying to stop it from becoming a full-blown disaster.
And contact tracing for STIs would fall here too.
Yes. You're finding the cases early to stop the spread.
And finally, tertiary prevention.
Think treatment and rehab. The disease has happened. The damage is done. Now we are trying to prevent it from getting worse or from killing the patient.
So this is the stroke victim who's doing physical therapy to regain function.
Yes. Or a nurse teaching a diabetic patient how to manage their foot care to prevent amputation. You aren't preventing the diabetes. That would have been primary. You aren't screening for it. That's secondary. You are managing the long-term consequences.
Primary, stop it. Secondary, find it. Tertiary, manage it. Now, we can't talk about primary prevention and vaccines without talking about the elephant in the room, vaccine hesitancy. The sources list this as a top 10 global health threat.
It is a massive challenge, and the sources highlight something really fascinating about the role of social media in all this. It creates these echo chambers.
Right. If a parent is anxious about vaccines, they go online, and the algorithms just feed them more and more scary, misinformation-filled content.
And the studies show that this fear sticks. Even 5 months after viewing anti-vax websites, parents still perceive a high risk. It is very hard to unring that bell.
So what's the nurse's role? Do we just argue with them? Do we throw charts and data at them?
No, arguing rarely works. It usually just makes people dig their heels in harder. The nurse's role is to first acknowledge the concern. Parents are usually trying to protect their kids. They're just operating on bad data. We have to build trust and provide clear, evidence-based information. But we also have to recognize the impact. The sources mention a pertussis, or whooping cough, outbreak in a charter school where many parents had filed personal belief exemptions.
And that's the herd immunity concept failing in real life.
Right.
One little pocket of unvaccinated kids can spark an outbreak that threatens the whole community.
Including those who can't get vaccinated, like immunocompromised kids or tiny infants.
Exactly. It brings us back to that ethical tension in public health. Individual rights versus the safety of the collective. Before we leave communicable disease, let's touch on 2 other specific areas the sources highlight: tuberculosis, TB, and STIs.
TB is fascinating because it's this ancient killer that just hasn't gone away. And for nurses, you really need to understand the difference between latent TB and active TB.
Okay.
Latent means the bug is basically sleeping in your lungs. You aren't sick. You aren't contagious. Active means it woke up.
And screening is key here. That's secondary prevention.
Yes. The USPSTF recommends screening for high-risk populations.
Yeah.
People born in countries with high TB rates, or people living in congregate settings like shelters or prisons.
And for STIs, the nurse often plays the role of the contact tracer.
Which is a very delicate job. You have to balance patient confidentiality with the duty to warn. If a patient has HIV or syphilis, their partners need to know, but you have to navigate that privacy very, very carefully.
Let's pivot to part 4. We've looked at bugs and viruses. Now let's look at the environment itself. The sources introduce a concept called upstream thinking. I love the analogy they use here.
It's a classic parable in public health, popularized by McKinley. Imagine you're standing by a river. You see a person drowning, so you jump in and save them. You pull them to shore, you give them CPR.
You feel like a hero.
You do, but then you look back and there are 2 more people drowning, so you jump back in, then 3 more, then 10 more, and suddenly you are just exhausted, pulling bodies out of the water all day long.
That's acute care nursing.
Yeah.
That's the ER. That's the ICU.
Right, but then someone looks up and asks, who is throwing these people into the river? And that is upstream thinking. Instead of just treating the illness, the drowning, you go upstream to fix the environmental or social cause.
So instead of just treating asthma attacks in the ER, giving the nebulizer, sending them home, you go upstream and ask, does this kid live in a house full of mold? Is there a factory next door pumping out smog?
Exactly. And this leads us to the social determinants of health, or SDOH, where people are born, grow, live, work, and age. The sources state that up to 33% of disease occurrence is attributable to environmental exposures.
That's a huge number. 1/3 of sickness is just where you are.
And it's not distributed equally. This introduces the concept of environmental justice.
Define that for us.
It's the principle that all people, regardless of race, income, or national origin, should have fair treatment when it comes to environmental laws and regulations.
But the reality is very different.
The reality is that low-income and minority populations often bear a disproportionate burden of hazards. They're more likely to live near highways, landfills, factories, or in older housing with lead paint.
So, as a nurse, how do I actually assess this? I can't exactly go inspect every patient's house. The sources give us a mnemonic for this. I prepare.
This is a great tool for your clinical pocket guide. It helps you ask the right questions during a health history to uncover these hidden risks. We can run through it.
Okay, let's do it. I is for investigate.
Investigate potential exposures. So you ask these open-ended questions. Have you ever felt sick after coming in contact with a chemical? Or do your symptoms get better when you are away from home?
P is for present work.
What do you do for a living? Are you working with solvents? Are you lifting heavy loads? Are you exposed to loud noises or needle sticks? Nurses often forget to ask about occupational hazards.
R is for residence.
When was your home built? How is it heated? Do you have mold? Do you have any drinking water issues? The basics of the home.
E is for environmental concerns.
This is the neighborhood level. Do you live near a landfill, a waste site, a busy highway? Things outside the four walls of the house?
P is for past work.
This is so crucial because some diseases have a really long latency period. Did you work in a shipyard with asbestos 30 years ago? Were you in the military? Did you work on a farm with pesticides?
A is for activities.
Hobbies. This is the one people miss all the time.
Hmm.
Do you garden? If so, is the soil contaminated? Do you fish? If so, are you eating fish from a polluted river?
That activities one is so interesting. You just wouldn't think gardening could be a risk.
Or what if you're melting down lead sinkers for fishing in your garage? I once saw a case of lead poisoning from a hobbyist who was making stained glass. You just have to ask the questions.
And the last two letters.
R is for referrals and resources, sending them to the EPA or the local health department. And E is for educate, teaching them how to minimize the risk now that you've identified it.
Okay, let's get into some specific hazards in our last part here, part 5. You mentioned lead. The sources are very specific about dates. This feels like a test question waiting to happen.
Yes, these are dates to memorize. If a home was built before 1978, it likely has lead paint.
1978, got it.
And if it was built before 1987, it might have lead soldering in the plumbing.
And why are we so worried about lead? What does it do?
It is a neurotoxin.
Mhm.
It's absolutely devastating for children. It affects neural development. It can lower IQ, cause behavioral issues, and the damage is often irreversible. The crisis in Flint, Michigan, which the sources discuss, was a catastrophic failure of upstream protection. They switched the water source, the new water was corrosive, it ate the old pipes, and lead leached into the drinking water. It created a generational health crisis.
Moving from water to air. The sources mention something called the Air Quality Flag Program.
This is a great example of nursing advocacy in schools. School nurses use colored flags, green, yellow, red, purple, to alert the whole school about the outdoor air quality that day.
So if it's a red day, maybe the kids with asthma stay inside for recess.
Exactly. It's simple, it's visual, and it's protective. It empowers the community to adapt to their environment.
Now what about fracking? Hydraulic fracturing.
This is a contentious issue, of course, but the data in our sources points to a Pennsylvania study about asthma, and it found that children living near gas wells were 1.25 times more likely to be hospitalized for asthma.
And nurses are often the sentinels here. They're the first ones to notice, hey, why are all the kids in this one neighborhood suddenly using inhalers?
Exactly. Before the big studies come out, the community nurses, the school nurses, they often spot the pattern. They see the incidence rising in their local bathtub.
Finally, we have to talk about what the sources call the greatest global public health threat: climate change.
It's not just about polar bears or melting ice caps. From our perspective, it's about human health. We're seeing heat stress, which kills the elderly and infants disproportionately. We're seeing extreme weather events, hurricanes, floods that destroy infrastructure.
And from an infectious disease standpoint, the bugs are moving.
Right. As the planet warms, vectors like mosquitoes and ticks are expanding their territory. So we're seeing West Nile and Lyme disease in places that used to be too cold for them. The environment corner of our triangle is shifting, and the agents are moving in.
And the nurse's role here, what do we do?
Emergency preparedness. Being ready for these surge events. When a heat wave hits and the power grid fails, The nurse needs to know who is on oxygen at home, who is bedbound, and how to keep them alive. It's all about resilience.
It's heavy stuff. But as we wrap up, I think it's also empowering.
Yeah.
We've traveled from Jon Snow removing a pump handle to a modern nurse checking air quality flags. The common thread is that the nurse is a guardian. You aren't just treating a set of symptoms, you're protecting the patient from their environment.
You are a data detective. You're a guardian of the environment. You are the one connecting the dots between the pothole and the broken leg, between the factory and the asthma.
And that leads to a final thought I'd like our listeners to mull over. We talked about evidence, but in environmental health, we often talk about something called the precautionary principle.
This is a vital ethical concept. It's the idea that when an activity raises threats of harm to human health or the environment, precautionary measures should be taken, even if some cause and effect relationships aren't fully established scientifically yet.
So it's basically better safe than sorry.
Essentially, yes. In a world of emerging chemicals, microplastics, and shifting climates, do we wait 20 years for the definitive study that proves X causes cancer? Or do we act now to reduce exposure? As a nurse, you will often have to help patients navigate that uncertainty. You have to balance scientific certainty with the duty to protect.
That is a powerful place to leave it. Next time you see a patient, don't just ask what brings you in today. Ask yourself, what is upon this person? Where did they come from? What is in their water, their air, their home?
Because that's where the real healing begins.
Thanks for diving deep with us. We'll see you on the next shift.